by welcoming you all and starting with paying my respect to elders past and present and acknowledging that we are on Aboriginal land. I'm here today in Meanjin, Brisbane, land of Turrbal and Yagara people. And welcome all. And very exciting day today with a topic of quite interest to youth workers now and for always it has been in terms of young people and drugs. Today we got a very special guest, Karl Lacis, who is an advanced AOD workforce educator. Works currently with Dovetail, but he's worked both here in Australia and in UK in prevention, early intervention, and treatment. So he brings with him a wealth of experience. So we're going to have very interesting information coming through, and then an opportunity to ask questions that you might not be getting answers elsewhere. So without further ado, I'll pass on to Karl to take us through his presentation. Thanks, Karl.
Great, thanks, Siavash. I'll pull up some slides and hope everyone can see them.
We can see them, Karl. Thank you.
That's great. I too would like to start by acknowledging traditional custodians in the lands in which we're meeting today. Pay my respects to elders past, present and emerging. And we're a statewide service at Dovetail. We're a part of Insight, and just draw attention to this beautiful artwork that was done by Bree Buttershaw. She's a Kalkadoon woman, which is around the Mount Isa region. And Bree was able to create this artwork for us, which kind of represents all the different wonderful parts of our state, both metro, land, sea, waterfalls, and, you know, up in the Torres as well. And that central motif being about connection. And today we're going to talk about young people and alcohol and other drugs. And we know that for our young people who experience the highest levels of vulnerability, including around their AOD use, that kind of collaborative and cooperative working and coming together in connected ways, that gets the best outcomes for those young people. So just wanted to mention that motif and, you know, a bit of the purpose for why we do the stuff that we do. A bit about Dovetail. So we provide training and support to workers, services and communities across Queensland, pretty much anyone who engages with young people impacted by alcohol and other drug use. We've got a weekly e-newsletter, so if you haven't subscribed to that, because the focus of your work mightn't be AOD, but certainly the scope of your work is going to be, you're going to be working with kids who use alcohol and other drugs. So there's a little QR code there. If that doesn't work, you can just subscribe on our website. So we send you 4 stories every week. It gets into your inbox at about 10 a.m. on a Friday. We scour the internet for, you know, the particular topical stories, young people and drugs. We'll write a little summary so you can kind of keep up to date with your professional development in this area. So a really good place to start talking about alcohol and other drugs is kind of considering our policy in Australia and the introduction of harm minimisation, which aims to prevent or reduce the harms associated with alcohol and other drug use. For people kind of around my age, you may remember Bob Hawke, who was the Prime Minister at the time. He went on to 60 Minutes and disclosed that his daughter had a heroin dependence. And that was a real watershed moment for Australia in alcohol and other drug policy. And so we saw the introduction of harm minimisation at that time. The kind of converse or the opposite of that, some people might remember the Just Say No campaign. So this was when Ronald Reagan's era in the US. So it was an attempt to kind of basically have zero tolerance around drug use, just say no, a really powerful message. And it got a lot of traction, but it basically, young people's experiences of using substances was very different to the kind of sensational messaging and of just say no. And basically a whole generation of US kids was kind of put off. Adults lost credibility because they didn't provide kind of accurate information, advice that was kind of in some way mirrored to the experience of young people. So harm reduction, harm minimisation in Australia, it's, you know, the 3 pillars of our national drug policy as it stands now. So supply reduction, you know, this is quite familiar to people who watch, customs and law enforcement shows. So, someone's bringing in cocaine through the soles of their shoes. But it's the ways that we kind of are able to kind of either outlaw and stop the supply of illegal substances, but it's also the regulation of legal substances. So you can think about age restrictions on drinking alcohol. You can probably be familiar with what's come through with the new vaping legislation. So ways that we can kind of control substances. The second pillar is demand reduction. So these are the ways that we try to assist young people to not to want to use drugs. So it's drug education in schools. It's an activity-based program. So all the diversionary activities, many of you folks in youth services and stuff would be running, cool, engaging programs that young people kind of are engaged in, and that's part of the demand reduction. It's also AOD treatment. So when people develop problems with alcohol and other drugs, that they can kind of get the treatment that they require. And then the final pillar, the ways that we try to kind of outlaw or regulate substances, or the ways that we try to educate people, or the way that we look to provide other programs so people kind of don't really want to use drugs. We're always going to have people in society that use substances, so harm reduction is an important pillar enabling us to kind of reduce the harms related to AOD. So your classic one are needle and syringe programs. But it's also things like chill out spaces. The chill out spaces are things like Schoolies Week or festivals. It's also things like giving young people emergency contacts, and when you're not, when something's not right with your health, or your mates aren't doing so well, that you should call emergency services. All the ways that we can think about ways to reduce harm. And harm reduction, sometimes it gets a bit mystified, but think about your own life. You put a seatbelt on to drive your car, that reduces harm. You put a helmet on to ride your bike. So a really important area for a lot of youth workers to think a little bit more around how we might reduce the harms of what young people are getting up to, particularly when they're not interested in changing their levels of substance use. And Australia was considered a kind of world leader in pioneering harm minimisation. With the introduction of needle and syringe programs, was the same time that HIV/AIDS was kind of sweeping across the world, and Australia had some of the lowest HIV rates in the world, in part due to the introduction of clean injecting equipment for people who inject drugs, who at the same time get a health intervention. A key message is reducing harm and promoting wellbeing kind of guides a lot of the work in this space. Moving on to kind of trends, medicinal cannabis is kind of, it's been around since 2016, but we've seen a bit of an uptick, and particularly calls to our service at Dovetail in relation to medicinal cannabis. Some of the advice that people were a bit confused about, well, young people were saying, well, I get this prescribed, this is my medicine, I should be able to smoke it on the couch in my resi care home. But, the advice around the medicinal cannabis, particularly the stuff that does have THC, is one of the cannabinoids. So it's an S8 drug. It's a drug that is like strong painkillers that you get for a broken leg. So how do you manage medication in your services? So it would be locked and stored, and it would be administered like any other medication. Other advice and things that we've spoken about to support youth services and youth workers is that you do get the flower forms of medicinal cannabis, but you can get it in other forms as well. So you don't have to be smoking it or vaporizing it. So tinctures and tablets and things like that, if that's the route that young people do go down in exploring the need for medical cannabis. Often we think about medications, not just medical cannabis, but young people are kind of, we've heard in and around, it's the silver bullet, this is the thing that works for me. But we'd really get workers and services to consider what are the range of holistic needs that young people have? And if a young person says, oh, I'm getting prescribed cannabis for anxiety, well, what else are we doing to assist that young person to develop skills and ways to reduce anxiety or manage anxiety? So good for us to think more holistically than just, oh, well, we can get medical cannabis now, so therefore that's the route that we should go. Could talk a lot on medicinal cannabis. There is an online e-learning on the Insight website if people are interested to learn more. It's really been fast-paced, a lot of profiteering in and around, companies wanting to make money. So getting good assessments for young people would be really, really important if they're choosing to go down that route of exploring medicinal cannabis. Counterfeit benzodiazepines, so these are things like Valium and things that help with anxiety and sleeping. We're seeing counterfeit benzos around for a while. You've got a couple of pictures there. Xannies bricks, you may have heard some of those slang terms before. We don't see it all across Queensland, but it certainly has kind of been something that's moved up from the Gold Coast. The Goldie seems to lead the way with a lot of new and emerging drugs. Go the Gold Coast. But we don't see it all over Queensland, but we've certainly seen it in a lot of regional centres. So the fake ones there, even the bottom one. So Xanax is a brand name for American alprazolam. So we don't have Xanax in Australia, but some people may import them, but more than likely it's going to be a fake pressed one. And you can see the Karma, which is a brand name in Australia. Our concerns for benzodiazepines is when they've tested the counterfeit ones that the dosage is often variable in different pills. So a young person might take one and then think, oh, this isn't doing enough for me, so I'll take 3. And then one of those in the 3 that they've just taken has a higher level of benzo in them, which mightn't be alprazolam. There's a whole bunch of different benzos. So their risk of kind of overdose or coming into more harm for accidents and injuries. So our harm reduction message is for young people to be really careful around using counterfeit benzodiazepines. One of them is around the dosage of the actual tablets that they're taking can be variable. Benzo are a depressant drug, so young people who drink alcohol and use benzos, those two depressant drugs combined, more likely for accidents and injury and those types of things, and probably risk of exploitation and things like that. So young people who do use these substances, some education around that is important, and looking after your mates and stuff like that as harm reduction responses. Nitrous oxide, NANGs, has been another one that we've seen on the increase, massive in the UK, and we have seen a big uptick in nitrous use. So NANGs, people might be familiar with. So these are the cream bulbs that you can see in that photo that are discharged into a balloon using a cracker device, or the old school cream bulb. So like when you go to a cafe and get an iced coffee, they put the cream in the cream bulb and then they use the nitrous oxide to whip the cream. So it's more for our younger or our older young ones, I should say. So kind of more our over 18s. We're not seeing our classic inhalant use for some of our young people who experience homelessness. They might be using deodorants and glues and things like that. Easier to access than perhaps nitrous oxide, which gives you, similar to other inhalants, a really fast acting effect. So there was a case of a 30-year-old guy on the Gold Coast who had nitrous while he was in the spa and actually drowned in the spa from the intoxication. So again, being mindful of environments and accidents and injury. There's also the risk of it comes out really, really cold. So freezing of the lips and things like that. And then there is also evidence around, things like heart conditions or heart, impacts on the heart as well with nitrous. So I'm running through these fairly quickly. If you want more information on any of these drugs, just get in contact with us, or there is some e-learnings to check out. But for some people, they just want to give us a call and have a chat about a young person they're working with. So we're happy for you folks to give us a call or make contact via email. New psychoactive active substances. So this is this range of often pills and powders that are either, drug chemists are wanting to look for variations. It used to be to avoid kind of drug laws, with slight variations, but now they've banned pretty much all substances of those variations. So whether it's drug chemists engineering them to look for a different type of drug and what effects it might be, or whether it's just, poor chemistry and things that have gone astray. So we've seen, the rise of those, which is quite concerning for emergency departments when people present and they're not sure what substances that those people have been using. And the one that we're kind of seeing, and it's really important for people to be mindful of and keeping an eye out, is nitazenes. So you may have heard of fentanyl, and it's really big in the the USA. Really strong opioids, so these really strong painkillers. Think of the opioids that you might use if you break your leg, like endone, but then there's also heroin. So nitazenes, super, super powerful, something like 50 to 500 times more stronger than heroin, generally speaking. But concerningly also is that they're being found in THC vapes. We don't see that many the THC vapes, but counterfeit benzodiazepines and drugs that you wouldn't ordinarily find opioids in, like MDMA, ketamine, cocaine, and other opioids. So, one of the messages to all people who do use drugs is to be mindful of these nitazenes. Not seeing it much in Queensland, but there was 4 people in Victoria not that long ago who they were at the pub and came home and thought that they were having a line of cocaine. They all had the line of cocaine at the same time, and it had nitazenes in them, and they all overdosed and died. So one of the big harm reduction messages for people who do use drug is that pretty much everyone who does use drugs should get take-home naloxone. So they should get an opioid reversal. It comes in a nasal spray these days, and all services should be thinking about how they're able to access this. AOD 24/7 is doing a postal take-home naloxone trial. Services can also contact them for how the service is able to kind of get on the program also as well. There is other information in the take-home naloxone toolkit on the Insight website. So, you might say, well, look, I'm in regional, Queensland, I'm in Rocky or wherever I am, and that's probably, not that's nothing for us to be worried about. It is around. We should be being concerned now. We should be getting naloxone now. We should be supporting the use of that for people who do use drugs. And kind of quite interestingly, we have got drug checking in Queensland launched. So this is for any person who intends to use drugs. These are both fixed site services based in Burleigh and Brisbane. So sorry, this is the southeast corner thing, but it is good to know that this is happening. So it includes under 18s. It's the usual if people are competent to understand what the service and treatment that they're getting. It's free and it's anonymous. People only need to bring a match head size sample and they get a health intervention while they wait. So depending on the person, they get some harm reduction advice and information or other health, and it could be connection to a service or something like that as well. So that's Checkpoint. You can see the little machine there. That's one of the chemists, so are able to, I think it's about 15 minutes, do the drug checking and provide that health intervention while that person waits. So with more of the arrival, and they're picking up a range of different substances, if you get on their website, you can check out some of their reports and see the types of things that they come across. Expanded police drug diversion program. So this is this move from more the justice response to a health response. So it's for low-level personal drug possession that police can now issue. They can just issue a warning, but they can issue also drug diversions. So our friendly folks at AOD 24/7 in Brizzy do the telephone diversions for the police diversion. It is, I think it's 50 grams for cannabis, and normally for your powders, it's 1 gram. and it does include under 18. So that shift, once again, people who work in this space, where we can shift to a health response, we tend to kind of get some better outcomes. And for those people who have kind of lots of stuff in vaping in schools or in and around the place, we do have new vaping laws and regulations, which is good to update people. If you're being confused, disposable vapes were banned from the 1st of July. I know they're still really easy to get, but only pharmacies can sell vapes legally. But from October, people 18 plus can purchase vapes without a prescription from a pharmacy. I think I'm not too sure whether there's that many pharmacies who are doing that now. So it's a bit of a tricky time and a transitional time. People under 18 will require a prescription. So if they are nicotine dependent, then that's one of the avenues that they could pursue, including other nicotine replacement therapies if they're looking to manage their nicotine dependence. And there is an Understanding Nicotine Vaping Products e-learning coming soon from Dovetail. Just because it's been such a topical topic, just wanted to show a slide on the vaping prevalence that we've seen. So this is the Australian Secondary School Alcohol and Other Drugs Survey from 2022-2023, and the lifetime use for 12 to 17-year-olds. We see 70% of young people 12 to 17 have never tried a vape. So I purposely have inverted my comment on that particular stat because, there is good evidence in the education that we give and the messaging that we provide to young people, whether it's school education or otherwise. If we overhype something or if we talk so much about, or this is so normal, every kid is vaping, it actually can be something that is just seen as normal. So we should be normalizing that actually 12 to 17-year-olds, the vast majority haven't tried a vape, and that's lifetime ever vaping. So, these stats aren't the be end and end all. They are surveys done in school, but it is good for us to think about our messaging around the normalization of kids, young people who don't vape, and also what are our responses to vaping. We've seen some pretty heavy-handed responses in schools for kids who are just, curious, they're trying it. So school expulsions and things like that. So for our young people who are just trying, they're curious, prevention-based strategies, this is our education in schools. This is, the types of balanced information that we looks a lot different to our young people who are daily vaping, or what sometimes get referred to as committed vapers, where we're more concerned about the harms around nicotine dependence, and ways, it's difficult for kids who are nicotine dependent to stay in school without, shooting off to have a vape. So what are our treatment responses to support them to either cut down, quit, or manage their nicotine dependence? So good to think about that. And we're not lumping all young people in the one basket in our responses, and we should be measured about what we do. There is a vaping toolkit. That's an example of one of the toolkits. So if this is an interest in your space of work or schools that you work with, there is some good resources there. We've had the opportunity to kind of do the deep dive and the research in and around that. So check it out. So that's a bit on trends. And if you want to have a yarn about any of that stuff, feel free to get in contact with us. And want to shift gears now to kind of understanding the types of lenses and frames for understanding alcohol and other drug-related harms and kind of ways to respond. So getting more into the practice side of thing. A good frame or a good thing to think about is substance use along a spectrum. So when we think about things like medicines or, other particular substances, they can be beneficial for us. So they give positive health, spiritual or social impact. So it might be, there was going to be a 2-hour community of practice. I'm going to have a cup of coffee to give me focus and alertness. And on the whole, it's a beneficial thing for you. Or it could be sipping wine in religious ceremonies. Then we move on to kind of non-problematic. So this is recreational. It can be legal or illegal, but the point really here is around that it has a negligible health or social impact for people. When we move into problematic use, the potentially harmful, we're starting to see negative health and other consequences. With harmful substance use, we tend to think of kind of the health harms, but really good for us to think more broadly about health, social impacts on school, impacts on hobbies, conflict with friends and family, and those types of things, and also the impacts on family and society. So a few examples there for you, like impaired driving, binge consumption, and changes to routes of administration. So someone might be going from smoking methamphetamine to injecting methamphetamine, and that comes with a range of potential harms there. And finally, down the kind of real pointy end of the problematic use is a substance use disorder. So these are disorders kind of assessed via the DSM-4, I think we're up to 5 now, and also the IDC-11. So kind of characterised by a lack of control of use, despite often experiencing many harms. So developing a tolerance, so needing more of the substance to achieve the same desired effect, and withdrawal symptoms. So when you don't have the drug, you're feeling quite ill and not well. So good for us to think about substance use on a spectrum and where young people might be at. And I guess looking out for some of the kind of signs that AOD use might be becoming a problem. And so of those, substance use disorder criteria, we've kind of put them into 4 areas for kind of ease of explanation. Having trouble controlling use, as you might expect. Using more than you plan, young people going out, saying they're going to have 6 beers, but then having 12 beers, saying that, they want to go hiking on the weekend, but getting too drunk on Friday night, just kind of canning that. So they're having difficulties cutting back or stopping, and cravings and urges to use, whether it's Friday night or payday, or if they've got feeling really negative moods, they might be looking to use a particular substance. Putting you or others in danger, really common for young people. So for young people, often their use is in outside environments or social environments, less so. Not every young person has got their own apartment. So often accidents and injuries are, more of the common types of harms that we see young people come to, less so the real long-term kind of physical harms. So putting your others in dangers, your classic ones like drink, drug, driving, but often for young people, and sadly we hear about it a lot, young people being exploited by others, even with the price of tobacco, cigarettes, there's a legal chop out there, but people being exploited with those large increases, and they can be put in danger, or it might be unwanted sexual experiences when intoxicated as well, things like that. Causing problems with life, hobbies go out the window, maybe, school's really dropping off, conflict with friends and family, and those types of things. And a common one that you would expect, some of those impacts on mind and body, and there might be a building up of tolerance or withdrawal, or some emerging mental health type challenges. And what we're kind of looking out for is that, we tend to see a real narrowing of experience. So hobbies start to drop away. You might start to see other things, fall away, conflicts with family. So they're the things as youth workers we want to kind of keep a bit of an eye on. A young person say, no, I don't have a problem. I don't see it, and what I'm doing is problematic. But just looking for some of those signs where there's a kind of narrowing of experience, where, it all becomes about scoring the drugs. I use all my money on drugs. I'm high on drugs, or I'm recovering from drugs. So this real narrowing of experience to a drug using experience. These are the things we want to look to try to identify and work with young people and kind of intervene where we can. Just want to show a short, I think it's about 2-minute video, which looks at how to have kind of, or guiding a structured conversation with a young person about their AOD use. So let's check it out. Can I just check that people could hear that when I had it on?
I couldn't, no.
Not coming through.
No.
So that might be problematic. what I might do is send the link. Oh, I did try this before.
If it's on your website, we can, after the session, if you send it, Carl, I will be sending a recording of the session and I can include that in that to everyone.
Might be able to get it up right now, Siavash. Can you edit the recording, Siavash, so we can cut this bit out?
Yes. While we're waiting for that, people, if you haven't done so, could you please put your name of your organization, and your postcode or suburb town you're in?
That's not going to work either. That's okay. I'll pop it in the link for people, and I'm happy to talk to it. It just was giving me an opportunity to have a break from talking. So the 4 L's is a way to guide a structured conversation, and it's looking at 4 life domains. So it's a mnemonic. It's liver, which represents physical and mental health; lover, which represents important relationships with people; lifestyle, which is the hobbies, things like school and work; and finally is law. So liver, lover, lifestyle, law. So law being the ways that young people might engage with the criminal justice system. So thinking about what's important in those particular areas to a young person, or problems that they may be having, and where substance use might be becoming a bit of a problem. So it's a way to kind of, and you, all youth workers, you'd be doing this in your general day-to-day conversation. How are your relationships going? What's happening at school? What's happening at work? Who's important in your life? Have you had contact with the criminal justice system? Do you want to tell me more about that? As you develop rapport, and to kind of create more purposeful conversations around AOD, it might be just kind of say, hey, do you think your cannabis use may have an impact on, you playing the clarinet or whatever it might be? So having a think about the insight that people might be able to gain through those conversations. Apologies for not being able to get that going. We'll send that through to you on the link. On this topic of, we've shared a few lenses around that kind of spectrum of use, signs things might be being a problem, and also, some guides for having conversations. And so kind of in that more kind of practice vein, how are we supporting young people, not new for youth workers, and really aligned to a curious inquiry approach versus investigation or interrogation. We may see the consequences of young people's substance use, and it might be a bit alarming for us, but it's really important that we stay curious in our approach to understand young people's experience, rather than kind of interrogating. If interrogation or investigation worked, a lot of us would be out of a job. What's the benefit and function of their use? So there's a bit of a reframe there for young people who kind of develop problematic substance use. They may have found their substance use, there's some kind of a solution in that. So what is the benefit and function of their use? So you can ask them, like, what are the good and not so good things about their use? So the good things about their use might be, it helps me sleep, it helps me relax, I don't have to think about my problems at work. So that's really useful, insightful information for us, and we can look to assist young people for maybe alternative ways to meet their needs. And the not so good things, notice the language there. It's not like what's the bad things, just thinking about language a little bit. What's the not so good things about their AOD use is, they are potential motivators for change. The not so good things are, I find it hard to get up in the morning, and I do like getting to school on time. Or the not so good things might be it costs too much money, or my girlfriend or boyfriend doesn't like it, or they don't like it. So these things can be motivators for change. For young people who really aren't interested in change, if it's not a problem now, what would it look like if it was becoming a problem? It's a really good framing question. You can also ask, do you know someone who does have a problem with alcohol and other drugs, and get them to kind of talk through that. So both of those things frame the question in relation to what a problem might look like. So if they say, oh, look, if I started smoking cannabis before school, that would be becoming a bit of a problem for me. Well, then if you notice that maybe they have started to smoke before school, then that's an opportunity for you to have a follow-up conversation and say, hey, you kind of said that smoking weed before school, that would be becoming a problem, and kind of notice that you've started to do that. So what do you think about that now? So it's a good framing question for a lot of young people who may not be ready to change their level of use, but getting them to develop a bit of insight for what a problem might look like. For your non-AOD workers, just being mindful of patterns of use that are emerging. So for a lot of our young people, their use is driven by access, what they can get their hands on. Whether it's payday or, they don't have lots of disposable income. So it can be quite opportunistic with big, siblings or friendship groups and those types of things. But good to keep an eye on just whether those patterns are kind of escalating. So whether it's they're using more of the same substance, whether they're using multiple substances, or it might be a change in the route of administration of they may have moved from smoking methamphetamine to injecting. So we want to be mindful of those types of patterns that we start to see. And also when they're not using, interestingly, asking people, are there times when you don't use, and what's that been like for you? And particularly for young people who maybe they identify so much with their substance use, those times when they're not using, it just kind of creates an alternative narrative sometimes. Don't focus on AODs when young people have got other stuff going on. So when they're in a crisis or they've got other issues that are, really, really important and a priority for them, that's not when we're going to be having those types of AOD conversations. And, any ways that support harm reduction and promote well-being is, I guess one of the key messages there. We've got permission to use this Stages of Change. It's from the Northern Territory. It's based around grog, but we really like it. People would probably be familiar with Stages of Change, the trans-theoretical model. We like the language in this one and also the motive. So people, if they're familiar with it, one of the things that we're really keen on is looking at ways that we match interventions to align to a stage of change. So not worried, the pre-contemplation stage, you can see the symbol really close to the grog and away from community and country in this example. So not interested, really normally pretty easy to pick. With people who are not worried, we're really just wanting to maintain a good positive relationship with them. We're not lecturing or hassling them. We're providing harm reduction information, advice. We're trying to link them in with their other hobbies and interests and kind of use those, work on things like what's in the 4Ls, work on those other life domains. And it's a really good message to give youth workers. A lot of work that you do is good AOD work. When I have my AOD work hat on, like keeping them engaged in whatever their interests are, keeping the routines up, help build stability in their lives. All of those things support young people, even though they might not be ready to change their level of substance use. So particularly for a lot of young people that aren't worried, really important message to share with all of you folks. The thinking stage, that's pre-contemplation. You can see the symbol turning away from the grog. So there's 1,000 reasons to keep doing what I'm doing and 1,000 reasons to kind of stop. It's a very ambivalent time. So that's where we look to try to build motivation with young people. And what would it look like if you did make a change? So they're the types of conversations. We've got a AOD intervention matching table, which I'll put in the resources for C of Ash to share with everybody. So there's a range of things that we can do across all those stages. In the trying stage, you can see the symbol moving away. That's a planning and preparation stage. think about changing your own life. You know, you didn't just change overnight. You had to kind of put some planning into place and preparation. Who's going to help you out? Who do I need to, stay away from? Or, do I need to, throw the ashtrays out or whatever it may be? The doing stage is the action stage, and you can see that the symbol has moved to closer to the community and also country. So that's the action stage. So we're really helping people to develop skills and build skills and maintain kind of what they're doing, which includes that kind of sticking to it stage, which is the maintenance. So we're in this particular motive, you can see that the symbol has moved out of the kind of circle of drinking and is closely connected to family, kin, and culture there. And lapse and relapse being a really important part of the learning kind of journey or stages of change. We can think about examples in our own lives where we didn't miraculously just not have any blips or mistakes on our life's journey towards things we wanted to change or do. So really nice use of language there. Oops, learning. Often people, a lot of people I work with in the AOD space, they get a lot of learning from that lapse or that little slip up stage, reflecting on kind of what changed or what got in the way or what kind of dropped off there. So I will share the matching AOD interventions to stages of change. It's a good worker resource for you folks to think about when you're working with young people. Goals aren't limited to abstinence, so don't have to be stopping. It could be reducing frequency. It could also be more safety, more safe use. And across all of those stages, we are providing harm reduction advice and information. Got a little activity you can kind of just do online. I'm not going to look at the chat. It's not easy for me to do while presenting here, but one important area is to thinking about AOD-related risks. So I'm going to present 3 scenarios. I want you to read all 3 of them, and you can probably just choose the scenario which has the most risk of harm from your point of view and have a think of the reason why. So a group of intoxicated young people leaving the pub and getting into a car and driving home. A 35-year-old mother injecting heroin with a friend while her 2 kids are sleeping in the next room. Or a 15-year-old girl being injected with ice, methamphetamine for the first time with her new 19-year-old boyfriend. So just pick one of those and have a bit of a think about why you might have chosen that one. What is it about it? And I'm just aware of the time, so I'll kind of keep pushing on through. When people choose a group of intoxicated young people, they're often talking about the risk to the young people and also the community, so the number of people. Obviously, driving, so the immediate harm, the risk could actually be really, really significant, including death. People with the 35-year-old mother injecting heroin, asking questions about the 2 kids' ages, so how young are the kids and their kind of that level of vulnerability, and who's the friend and things like that. And then the 15-year-old girl being injected with ice for the first time, talking about the age difference, and also that the young person who's methamphetamine naive, that they likely haven't tried the substance, so they don't know much about dosage, and also who is this 19-year-old fellow, like what's his intentions. Obviously, they don't have all the information there, so there's gaps to kind of that you do feel. So to say there is no right answer, there isn't any of those is the right one. Sometimes in face-to-face training, I forget to tell people that and move on to the next section. So that can be problematic, but there is no right answer. But the point of doing that activity is wanting to share this particular frame with you. So thinking about what you would do when you're kind of thinking and trying to judge all of these is thinking about the interrelationship between the drug, the person, environment. So 15-year-old girl being injected, the route of administration for drug, methamphetamine, quite, a pure form of amphetamine. The person 15, her age, she's meth naive, so her inexperience with the drug would mean she potentially knows a little bit less about it, and the environment. So this 19-year-old fellow, like what are his intentions, or kind of what's going on there? So there is a video, Universal Harm Reduction Advice, which has got a link there, so you'll be able to check that out to learn some more. So when we do case conferences with child safety, this is the frame that we often use, because we identify what the risks are in those particular areas, the relationship, and where can we provide some kind of intervention, or where is there opportunities to reduce the harm, whether it's education for the young person, helping them access clean injecting equipment, or it might be some insight building around relationships they have with other people and things like that. So you can check that video out. The final one that I wanted to really bring in, we've been speaking quite focused in that judging risk and other things all about the drugs, is to really consider and really relevant to all that we do, work that we do, is the factors that influence problematic AOD use. And we really like this resilience scale that comes from Alberta in Canada. So resilience being the ability to respond positively in the face of adversity. And the scale looks at the kind of positive supports and enabling environments. Firstly, it looks at buffering toxic stress. So these are toxic stress or experiences that we have where we don't have kind of supportive people around us, often experience that, in our earlier years, but also it can be at any time. So those types of negative experiences that we experience. On the positive side, so looking to create enabling environments and positive supports. So who's around us? What are the cultural connections that we have? Who are the positive supports that enable us to kind of develop resilience or feel like the world we can kind of get on in it? And you can see the fulcrum, or that kind of tipping point, moving with the people there. I think I can stop it because it'll probably drive people crazy looking at that scale going up and down, is that the fulcrum or the tipping point isn't fixed. So I can stop it again. That young people can develop skills and abilities to build resilience. And that's often where we focus our efforts, and we really need to be mindful of those three areas of the scale. So we may actually have a role in supporting young people buffering from toxic stress. A safe drop-in space for young people is assisting them to buffer toxic stress. It might be creating enabling environments by helping young people who have never really played much to, play, or that your approach as a youth worker that supports a kind of playful interaction as they develop and learn. And really importantly, those bottom ones that help shift the fulcrum around modelling and supporting self-management skills. So they're your kind of common things that we think about when working with young people: emotional regulation, being able to kind of manage what's going on, coping with stress, planning and problem solving, meaning making, and getting needs met. So you can check out that resilience scale if that's of interest to you. We find it a really good metaphor to describe what, the interaction between the types of things that are going on for young people. So in summary, effective responses to vaping, look aligning, and it's similar with all drugs. We need to have them aligned to motivation, attitudes, and current behaviours. It's been a whirlwind tour for this little session or presentation, but for our kind of non-vapers or curious vapers, it's a different response to the ones who are nicotine dependent. That's the current behaviour. Definite concerns regarding nitazines, these new strong painkillers that we're starting to see come through, and our responses need to include educating people who do use drugs that nitazines are being found in across the board in different drugs, and naloxone is opioid reversal drugs, really, really important for people to have, and we're talking about young people, but this is for all of us. We all know people who use drugs, or we may use drugs. Naloxone is something that we should be carrying and supporting people to have. Work with what's important to the young person, explore how their AOD use may feature. So that's the kind of place where we start. We might get a bit too focused on the drugs when, our just good youth work abilities to support young people with what their interests are, what their goals are. That's good. That's good, whatever that good youth work looks like, and how their AOD use might start to impact on those important things in their life. Identifying the function and benefit is a good way to help conceptualize or think about young people who do start to develop problems with their drug use, because they've found some kind of solution for what's going on. We've talked a little bit about the stages of change, and our responses can kind of really match where young people are at, whether they're not interested in changing behaviour or whether they're kind of starting to think about it or actively wanting to kind of develop goals and plans. We can identify and respond to the harms or potential harms through that drug person environment lens, and helping build resilience. So it's that real bigger picture stuff around supporting young people. And I guess as a point to finish on, often the direction of our work, if we're working with a young person who's in crisis, we feel like we're not, necessarily doing a good job because they're going from crisis to crisis. But that's our goal. Our goal is just safety. They're coming back to the house. That's good. Our goal is to help to move that young person to some form of stability. It's only from that base of stability can they form greater connections, can they develop their routines, can they build skills and abilities to help develop resilience and, hopefully develop a greater sense of well-being. So that kind of, stage process from just safety, stability to greater participation and connection is something good to think about on the road to developing resilience as well. So check us out at Dovetail. These slides will be available to folks, and that's where you can navigate all of our resources at Dovetail. I did mention ADIS 24/7. They do the postal naloxone, but that's a really good service to know about. Also for referral options for young people as well, if you want to know about what services are out across the state. They are statewide and they're 24/7. And that's us at Dovetail. Feel free to get in contact, and thank you for having me, Siavash, and the Community of Practice crew.
Thank you so much, Karl. Amazing presentation, so much information. It's amazing.
Probably too much.
Okay, welcome back, everyone. So in this next part of the session, just a report back from each of the 5 groups in terms of what was discussed in your small group. I don't have the name of everyone in the group, but I've just jotted down name of one person from the group. So whoever is going to be your spokesperson, one group that had Charlotte in it, that group, Charlotte or one of your colleagues.
So one of the things that we talked about was advocacy. We need to advocate for the young people more, and to also how to tell whether or not it's mental health issues versus drug issues that the person is going through, because sometimes they can look like the same thing or they have the same symptoms, but that we worked out that probably not going to know that until you get to know them for a bit. So in a couple of us, we can do that. We're working with young people long term, but 2 of the ladies are in legal, so they won't get to see them for they won't get to know them long term. So it's a bit difficult for them. Also trying to get policies and procedures in place regarding medical marijuana, because it is legal in certain circumstances now rather than being illegal. So needing to make sure that we're doing the right thing for everyone involved with that one.
Great, Juke. Thanks very much. Great summary. What about the group who had Maria in it? Maria or someone else from your group that?
I think that was me. Maria's in a conference room and doesn't have access to a microphone, so I'm happy to relay
Thank you.
group number 5. So we kind of just discussed the different in age brackets in terms of our services, but I think something that we all had in common is that all of our services have a harm minimization approach, whether we deal with drugs directly as our service, or for me, I work for a headspace center, and it's one of our 4 core streams. And we have that harm minimization approach that, you know, it's dependent on each of the client's needs. We kind of talked about some of the themes in the substances that were probably of most use. And again, as it was kind of iterated in the session, it's those things that are mostly cheap and accessible. So chroming is a big issue, but also ice and methamphetamine over the use of opioids. But we also kind of talked around a lot the idea of medicinal marijuana prescriptions. And for myself in the mental health industry, we're seeing that especially between 18 to 25-year-olds, that access to medicinal marijuana prescriptions is actually quite common and quite easy, especially through a lot of online services. And we kind of, again, just talked and debated and reflected about the appropriateness of suggesting, recommending, or even referring young people to get those prescriptions as a harm minimization approach. Because is it safer for young people to be doing something that is reasonably regulated, and having those prescriptions and having that access to mental health professionals rather than to be doing ice, methamphetamine, chroming, and even just, I guess, some of the benefits of having access to medicinal marijuana rather than street weed and not knowing what's in it. And we didn't really come to a conclusion. It's something that, in terms of the appropriateness and the risk, is it our position to be making those recommendations or suggestions? And is it actually, like, where is the data that proves that this is safer than some of those alternatives?
Great point. There's no clear answer, is there? It's food for thought. We need much more discussion and deliberation, but yeah, definitely. Thanks very much, Sherry. What about the group with Michelle? Anyone, Michelle, or anybody else from your group?
Yeah, I can probably talk to what we spoke about. We're all from like sort of have different type roles in terms of working with young people. So some of us were from more so that referral pathway provider where we might have sort of that limited or initial contact, but it might be having that engagement, say, over the phone and building that rapport with them over the phone to be able to refer them into the right services, which might be a substance use related service. Others have like more sort of one-on-one work with young people. What we mainly spoke about as a group, as a whole, in terms of what we took out of Karl's presentation was his suggestions around how to engage young people, not being judgmental, being really careful and mindful of the language that we're using when working with young people who are using drugs. As Karl mentioned, that language around what are the good things and what are the not so good things about your substance use. We also spoke about being more curious with the young person around their substance use and trying to find out, how they view it and all of that, not diagnosing or anything like that, knowing when to refer on to maybe a service that specialises in AOD treatment. But yeah, mainly we sort of took those how to engage a young person, how to create that positive, safe space for the young person. So even if they're not ready to address their substance use or make changes, it's about creating that safety so that hopefully when they are ready, they come back and they go, okay, I remember that service, and they were really supportive. I feel like I can go back there to get some help with this.
Great. And that was the topic of a couple of our recent sessions in terms of building trusting relationship with young people. So important. I mean, that's the bread and butter of youth work. If we can't do that, we're not youth workers, really.
Yeah,
Yeah.
absolutely.
And you get a prize for having a name trickier than mine. How do you pronounce your name?
Oh, Meg, sorry. It's actually Caitlin, but for some reason on my Teams, I think because it's the Queensland Health, that's my login. That's what it comes up as.
Okay.
Comes up as. Yeah. Sorry about that.
I struggled trying to say, how do I pronounce this name? Osilo Vanchai. I thought it's Italian. Okay.
Yeah, no.
Thank you. All right. No prizes for you. Okay. Group with Joe. Is Joe not even here? Is Joe here? Yeah, Joe's here. Either yourself, Joe, or someone else that was in your group?
Donna, so that's me.
Yep.
We spoke with Paul, who was really interesting. We spoke about the 4 L's and we thought how that was great. And we probably all have those conversations without realising that we're structuring it. That's how it's structured, the 4 L's. So just in those conversations we often have with young people, relating to all of those different relationships and all of those things. We also spoke about communication being the biggest part of it. So if you can have that open communication, non-judgmental with these young people, you're actually going to have that conversation. And it allows them to be open and honest with you. And we're sort of talking about, we're all parents, so we're talking about our own children, because even as people who work in this field, everyone has this struggle. Teenagers are teenagers. So we were talking about that. We come from the employment sector. So, and we're in Gladstone, very big industrial town. So their drug use really minimises what type of job they can apply for in this town. And these boys want to come in and they want those good industrial jobs. And so that's the conversation you're having with them, that these are the choices you're making is limiting your life. So your goals, how are you going to reach your goals if you continue on this path? So we do see young people really turning around because that's the reality of their goals, and what they're doing is impacting their life. Yeah, so we're sort of having those sort of conversations. So it's really interesting. Yeah.
Right.
We also spoke about the ease of these young people getting it. My background is school. So what I learned at school is it didn't matter where they were, they could get on very, very easily through social media, something that we sort of all learned. I didn't realise was a thing. So that was also really frightening, just how easy it is.
Snapchat?
Yeah, Snapchat, all of those different platforms. So we had those conversations too.
Yeah, different challenges, and I guess it's different thing. That was like, in terms of supply reduction, that's one end, but from our end of it, leave that one to the law enforcing. From our end of it is what you said, is those relationships again. So, and young people themselves feeling comfortable to come and talk, and at least knowing that by saying to us, divulging that they're on any particular drugs, we're not going to freak out or call the cops or anything, that we'll still be with them, supporting them to make healthy choices. That's great.
So, yeah.
Thank you. Okay, group with Phil. Phil or somebody else from your group that could report back? Anyone, Phil, from your group that's still there?
I'll talk. So we had a discussion around a couple of the points in the workshop that seemed to work well with the way I might work and other people. So the reframing language one was one that we thought was pretty important, like that, just that not drugs are bad, to quote Southbank, drugs are bad, kids, drugs are bad. It's about that
Park or something, is it?
Well, that was on the cartoon Southbank. South Park.
Yeah, Karl, yeah.
Kids, drugs are bad. So it's about reframing that and saying what was not so good. I actually quite like that concept. That's something I'm going to adopt straight away. I've never actually framed it like that before, because we talk about drugs with young people, what's good about them and what's bad about them. What I like that, what's not so good, yeah. We also talked about picking a place for conversations around drugs, depending where you are, depending on the young person's circumstances, we can have that conversation. And a couple of the workers really, it was just a big learning exercise that I've just taken a lot on board, and they're still thinking about how they're going to implement that in their day-to-day work, I suppose. Did that cover everything you think, people? Yeah? Yeah.
Thanks, Phil.
Yes, Phil.
Go ahead.
No, I'm done.
All good. Anything else that anyone wants to say, question or comments about the session, about anything that was talked about today? Anything else that you think would be good for us to look at in terms of future sessions? Any sort of speakers or topics that you think relevant to the discussion today?
I was gonna say, just to add out with because I was in field group, we also talked about how the importance of understanding the youth. Like I know somebody mentioned building a report, and I know like most of us, when we say, oh, this young person uses drugs, especially in a community perspective, we tend to judge but not understand why are they taking the drugs, what are the reasons. It could be trauma from a family or not having a great role model, or so for me, coming from a child safety perspective and dealing with parents, seeing the child being taken away because of high, the amount of drugs used, and then leaving that and moving to a community perspective organizations where working with young youth, how do we prevent, like working with early interventions, having a space where it's more like a rehab space that we deal with here. So where all the young peas will come here to just spend the time here, do the stuff that they need to do just to keep them away from even having that talk, that our cultural or gathering where you talk about certain things, what's bothering them. I feel like for me personally, I was a judgmental person where I'd be like, why isn't drugs? This person is this and that. But I guess today's lesson has kind of taught me to understand the type of drugs can be used for my kids and my generation, also my community, and also the reasons why, instead of judging. I guess for me, that was something that I've learned was knowledge, and which from moving forward for my continuing practice, it's going to help me to understand the young peas more, and like in the youth, being youth mentor or youth worker. It's like you said, if you can't understand your work, your young people, what's the point of you being a youth mentor or guidance or role model? So that was something that we discussed, and also the system, how the system sometimes spends so much financial in developing others that are not necessary, but instead of building a space for rehab. And that was the other thing that we talked about. Yeah.
That's a great point. Yeah, thank you. I think that was great. Yeah, we're really short of detox and rehab places across Queensland. There are many young people up and down the coast that are trying to actually get off drugs, and the drugs that actually require the residential support. So it requires medical support. But unfortunately, yeah, they can't get to those places. So we get constantly called by community members, youth workers saying, do we know any places? And unfortunately, we just have a shortage of beds.
Clarence Street is the only place that I'm really aware of that accepts young people for living residential, and they're still only short term living, just little blocks of a couple of weeks, not 3 or 6 months like adult rehabilitation services have.
Yeah, that's Southeast Queensland. And then Rockhampton. Is there anyone from Rockhampton and Townsville? Yeah, Sherry.
Yeah, so we have, as far as I believe, we have 2 rehabilitation services. Lives Lived Well has a rehabilitation service for young people, and I think the ideal time frame, and I'm not quite sure, is between the 8 to 12-week programs. They also have a detox clinic that's at the rehabilitation centre. which, yeah, we did a tour of quite recently, which I think is pretty cool. And then they have one that is First Nations funded, but not restricted to First Nations people as well.
Great. And that's where, Sherry?
This is in Rockhampton.
Great. Yeah. And does anyone know about Cairns Townsville? I believe that there is a service up there that was established not too long ago. No one here. We can, I'll check that and I can send that information with the email that you'll get, which will have the recording from today and resources that Karl mentioned. Any other comments, questions?
I might jump in real quick and just you mentioned advocacy, and I think that at the moment that's a particularly important topic as we see this current political campaign hinging on vulnerable young people and really using them as scapegoats. And I think there needs to be a response, ideally, or some information on how best to respond to those sorts of themes. It's really unhealthy and it's really sad to see. So maybe there's a topic for a future session. But yeah, thank you for today, Siavash. It's been really great.
No, that's a good topic. So generally advocacy around young people's issues.
Yes, I think, yeah, there's a need for that.
Yeah.
Isn't that interesting? Because Yank was the advocacy body for young people, was defunded by Campbell Newman. And when Labor got in, I thought, great, they'll get refunded. Well, I was naive because no government likes an advocacy organisation. And unfortunately for Yank, our state peak body stepped in and took money that should have gone to Yank. They were complicit in the defunding of Yank. So that's how much they like advocacy. QCOS got a lot to answer for as far as I'm concerned.
Yeah, I think some of that backstory, that sort of detail around the previous 10 years that may have led to the situation that's currently being, media driven, would be valuable.
Thanks very much. Thanks, Drew. Sherry's put a couple of links there in the comments to what she was talking about, services in Rockhampton. So if you're wanting to download them, do so before we close the session. Any final comments, questions before we close this session? No? Okay, well, thank you all for your patience, for your participation. It was a great session. Hope you got something out of it that you can take back to your work, and also recording will come to you. So if you're also wanting to share that with your colleagues at work or broader networks, do so. And please invite them to join this community of practice. We've got overall about 240 people from across the state who have joined this. Not everyone participates every session, but it is a community that's growing. And so hopefully together all will continue to learn and share information and grow and help develop better and better services for young people and collective action, advocacy, and all of that. So thank you again. All the best, and I'll see you at the next session.
Thank you.
Goodbye.
Goodbye.